Hello and welcome to the Super High Yield Anesthesia Podcast, the second edition. This is your host, Scott, the anesthesia resident. Well, thanks for tuning in to the Super High Yield Anesthesia Podcast. So we are going to continue our discussion on neurochemistry of somatosensory and pain processing. In the last episode, we kind of talked about the inflammatory soup, so how important things like bradykinin and histamine are in the pain response. And we also kind of talked about different things like anti-hyperalgesic mechanisms, so like opioid receptors. And we started our conversation on neurochemistry of pain transmission. So specifically, we talked about excitatory neurotransmitters, things like glutamate and aspartate, and talked about NMDA and non-NMDA receptors. So now to continue the conversations, we're going to talk about inhibitory neurotransmitters in this episode, and we're going to move on to talk about neuropeptides and different central signal propagation, so like the different ion channels that's involved in pain signaling, and as well as second messenger systems. So with all that said, let's go ahead and get started. So there's a pretty large variety of inhibitory neurotransmitters. The ones that you're probably familiar with are things like glycine and GABA. But the other ones that we're going to briefly talk about are actually kind of interesting. Norepinephrine, serotonin, adenosine, and acetylcholine. And as with before, we're going to kind of go through these one by one. So first one is glycine. And as you probably already know, this is the chief inhibitory amino acid at the spinal level. And glycine has two specific receptors. The first one is a chloride-linked strychnine sensitive receptor, and the other is strychnine insensitive regulatory sites on NMDA glutamate receptors. As you remember from the previous episode, the spinal modulation has both excitatory and inhibitory components to it. So it's kind of like the similar idea as sympathetic and parasympathetic, where there's a push and pull kind of a relationship. And this is no different. So we have the excitatory component, so things with like glutamate as for the excitatory portion, and then glycine as the major part of the inhibitory portion to modulate spinal signals and whatnot. Okay. So glycine, that's the first one, and is probably the most important one. Next is GABA. This one is going to be the chief inhibitory amino acid at higher levels. So beyond the spinal level, so I guess in terms of supraspinal cortical sites, that kind of thing in the brain, there are three types of GABA receptors: GABA A, B, and C. So GABA A is linked to chloride channels, and it's modulated by things like barbiturates, benzodiazepines, alcohol, and there's different types of agents that kind of act on this GABA A receptors as well. So selective GABA A agonists includes things like mucimol. Selective GABA A antagonists are things like gabazine. And the last thing to know about GABA A is that it mediates the link between large myelinated fibers and C fibers, which is the proposed mechanism for allodynia. And if you don't know what allodynia is, basically it's when a patient experiences severe pain that's caused by stimuli that's not particularly associated with severe pain. So things like light touch or like rubbing blankets or sheets over your skin and it hurts a lot. That's something that's not particularly associated with pain, but it does cause pain in patients with allodynia. And that's actually an important thing to know for boards. That's why I spent a little bit of time on it, because you need to differentiate the difference between allodynia and hyperalgesia. And as we discussed in the previous episode, hyperalgesia is exaggerated pain due to secondary to a painful stimuli. So So it's pretty much like an amplified version of it. So if you get stubbed your toe and it feels like someone chopped it off, that's hyperalgesia. Okay, sorry for the little detour, but again, relatively important to know for boards. Okay, so that's GABA A receptors. Next is going to be GABA B. This is a potassium ionophore or G protein linked complex. An example of drugs that acts on a GABA B receptor is baclofen, the muscle relaxant, and it's a GABA B receptor agonist. Okay, and lastly for GABA, it's going to be GABA C, and it's also associated with a potassium ionophore. And at this point, I don't do any of this research, but there's no known role in modulation of somatosensory information. Okay, next is norepinephrine, and again, is one of the inhibitory neurotransmitters. And it's important in a descending brainstem projections to the dorsal horn. The mechanism behind why norepinephrine is an inhibitory neurotransmitter is that it directly acts on the inhibitory GABAergic interneurons, and it also directly inhibits excitatory interneurons. It also has alpha-2 adrenergic receptor activity, in which it is primarily located in the spinal dorsal horn, and it also has inhibitory role in sensory processing. Okay, so that's norepinephrine. Next is serotonin. For serotonin, it's expressed in descending pathways to the spinal dorsal horn, and it originates from the midbrain raphe nuclei. And different receptor subtypes are 5-HT1, 5-HT2, and lastly 5-HT3. And this is kind of why I can use things like duloxetine or amitriptyline in terms of pain control, like beyond using it for as a psychogenic medication. And the possible mechanism behind this is that it's mediated by activation of alpha-1 adenoreceptors and 5-HT2 receptors, so it causes descending inhibition. Okay, so that's serotonin. Next is adenosine, and adenosine acts at the spinal level, and there's two main receptors for adenosine. It's A1 and A2. And activation of these receptors leads to G protein mediation, changes in CAMP levels. It mediates a portion of analgesia that's produced by brainstem norepinephrine, and it helps with neuropathic conditions when you target it. Okay, so that's adenosine. Next is acetylcholine, and this acts at the level of the spinal dorsal horn. It causes stimulation of the vagus nerve, which leads to inhibition of pain transmission. And another example of medication that acts on this is clonidine, as several nicotinic subtypes are involved in different pain states. And so yes, acetylcholine is involved in the stimulation of the vagus nerve and inhibition of the pain transmission that way. Okay, so next we are going to move on and talk about neuropeptides. And neuropeptides generally have a gradual onset and a longer duration as opposed to the other inhibitory substances. And the ones that we're going to talk about specifically in this section are substance P and neurokinin A, CGRP, SST, cannabinoids, and peroxisome proliferator activated receptors, PPARs. Okay, so substance P and neurokinin A, these are excitatory, especially substance P. These ones will act on neurokinin 1 and neurokinin 2 receptors. And by acting on these receptors, it increases intracellular calcium levels. And from here, it sensitizes a neuron to pain signaling. So it makes it more frequent for these neurons to cause an action potential. These neurokinin receptors are concentrated in the primary afferent fibers. And at the spinal level, it's released after sustained noxious stimuli and C type nociceptors. And in the dorsal horn, it kind of spreads throughout, and it potentially acts on multiple synapses. So knowing this is what substance P and neurokinin A is important is because activation of neurokinin receptors by substance P or neurokinin A is needed for sensitization and development of hyperalgesia after cutaneous injury. Okay, so substance P, neurokinin A. Next is CGRP. And this is mainly expressed at the unmyelinated primary afferent fibers, but it's also found in the dorsal root ganglion cells on superficial layers of the spinal cord. It increases the release by, so neuropeptide Y increases the release of CGRP. And the reason why this is important to know is that it has excitatory effect on wide dynamic range neurons. Some studies have shown that intrathecal administration of CGRP causes mechanical hypersensitivity, but other studies suggest that CGRP released in the brain causes anti-nociception. Okay, next, SST, so enkephalins and dynorphins. These are primarily inhibitory neuropeptides. They are contained in the intrinsic neurons of the dorsal horn and in fibers descending to the dorsal horn from various brainstem nuclei. Regarding these endorphins, these are a class of inhibitory neuropeptides, so they act on different receptors, so like mu, delta, and kappa receptors. So these are found at all levels of the somatosensory system, and it's associated with modulation of intracellular cAMP and potassium levels. So as we kind of talked about earlier regarding anti-hyperalgesic receptors, in terms of like opioid receptors, you have like the intrinsic mu, delta, and kappa receptors, and these things like this, the endorphins, the SST. This thing is the one that could act on those intrinsic receptors. Okay, next, cannabinoids. So receptors in both cannabinoids have receptors in both the peripheral and central nervous systems. In the central nervous system, this is the thing that we're going to talk about the most. There's two types of receptors, CB1 and CB2. CB1 is highly expressed in the dorsal root ganglion. An example of a CB1 receptor agonist is medication Sativex. And CB2 receptor appears to be right now be used in like the research stage. The agonism of the CB2 receptor with a molecule called AM1710 decreases allodynia by paclitaxel in a mouse model. And another study showed that agonism with molecule JWH133 decreases pain response from osteoarthritis pain. Okay, lastly is the peroxisome proliferator activated receptors, or PPARs. These have a nuclear receptor that encodes transcription factors. There are three types: PPAR alpha, PPAR beta / delta, and PPAR gamma. So PPAR gamma, it attenuates inflammation. And it's interesting because you probably heard of PPARs from your studies in terms of diabetic medication. So things like rosiglitazone, which the glitazones are associated with controlling diabetes, but there is ongoing studies to see if it's possible that it can modulate neuropathic pain. Okay, so in this last section, we're going to talk about the central signal propagation and second messenger systems. So basically, we're just going to talk about a bunch of different ion channels that's related to pain signaling. So these ones are going to be sodium channels, potassium channels, calcium channels, and lastly, chloride channels. So for sodium channels, this is going to be as you probably already know, the primary method of depolarizing nerve membranes. So as a quick review, voltage-gated sodium channels allow sodium to enter the cell. So it's higher concentration on the outside, and then when action potentials happens, it goes on the inside. Strangely enough, these questions on where the sodium is and where does it go, and like the other stuff like about the other ion channels is actually commonly tested for some reason. So just make sure you get these straight and when you're preparing for boards, because it's going to be very easy questions to get right. Okay, moving on. Sodium channels in dorsal horn is mediated by three types of tetrodotoxin sensitive channels. And there's a few different sodium channel subtypes, NAV 1.7, NAV 1.8, and NAV 1.9. Of the 1.7 sodium channel is important because patients that lack this subtype have insensitivity to pain. So overactivity is, so basically it's implicated in pain because like if you don't have it, you don't really feel it. So, and the other side of the spectrum, overactivity of this specific sodium channel type leads to chronic pain. And a drug that targets the NAV 1.7 channel is carbamazepine, the drug that's normally used as a first-line treatment for trigeminal neuralgia. Okay, next receptor is NAV 1.8. This one is still in the research phase in terms of developing drugs against it, but it's found that mouse models lacking this has decreased response to pain. And lastly, receptor 1.9 is possibly implicated in trigeminal neuralgia. Okay, remember, just because it's so high yielded in terms of getting a question right, sodium, primary method for depolarizing nerve membranes, is most of the concentration in like a neuron is on the outside, and once it depolarizes, it goes on the inside. And I know it sounds like really basic, and me saying this sounds kind of stupid, but it's weird how often this shows up not only for ITE but also basic. So that's it. That's I'm going to stop talking about sodium channels now. So we get even better. Potassium channels. Yay. So there are four families of potassium channels. There's voltage-gated channels and inward channels that are most implicated in pain. And this is the converse of sodium, where at natural state, potassium is intracellular, and during action potentials, potassium goes out, right? So again, during voltage-gated potassium channels allows for outward flow, and it causes repolarization of a neuron. And blockade of a voltage-gated potassium channel prolongs generation of action potentials. And a drug that is a potassium channel blocker is something called retigabine. Has been shown to reverse surgically induced neuropathic pain, although it's not particularly widely used yet. And the K2P channels, the two pore potassium channels, are now the target of potential research and development for new drugs. Okay, that's potassium. Next is calcium. And calcium is important for the release of neurotransmitters after synaptic depolarization. And this is also a high yield board point where potassium in the presynaptic neuron is important for formation of the vesicles that ultimately allow for the release of neurotransmitters in the synaptic cleft and ultimately into the postsynaptic neuron. So again, calcium is important for the release of neurotransmitters. So there are different types of calcium channels in the dorsal horn. There's four different types of calcium channels in the dorsal horn. It's type L, N, P, and T receptors. Type L calcium receptors are the most common blocked receptors for the current medications. Type N calcium channel receptors is blocked by toxins like Conus magus. Type P receptors are prevalent in Purkinje cells. So if you think P for Purkinje, that kind of helps you memorize it. And this is particularly sensitive to the venom of the funnel web spider. And the funny thing is, it's really it's a deadly venom from the spider, and of course, it's actually found in Australia, and it can kill a human within 15 minutes. So, if you go to Australia, or if you happen to be from Australia, don't get bitten by this. And why is everything that why does Australia have everything that's trying to kill you? And like you're trying to go to the grocery store or something, and you're just like afraid for your life. But I don't know. That's coming from someone who just understands the world through memes. But okay. Anyways, next and the last type of calcium receptor is type T, and this is involved in regulation of neuron excitability and pacemaker activity, and it's blocked by omega chronotoxins. And lastly is the chloride receptor. And there's three major classes for this. There's ligand-gated, voltage-gated, and CAMP. So ligand-gated are commonly activated by the GABA-A and glycine receptors, and it causes the chloride to enter. And these are commonly found at the dorsal horn. So again, if you recall from earlier, glycine is an inhibitory neurotransmitter, and again, it's chloride-linked strychnine-sensitive receptor. Okay, and GABA-A receptors. So things like barbiturates, benzodiazepines, alcohol act on GABA-A, causes chloride to enter the cell, and causes hyperpolarization. Okay. Next, voltage-gated chloride channels, as you know, the chloride starts on the outside and then it goes in through the voltage-gated channels. And lastly, the CMP chloride channels is the cystic fibrosis transmembrane regulator. So yes, the main idea for chloride is the currents that enter the cell causes a hyperpolarization of the neuron. All right, so that just about does it for this episode. And then this is part 2 of the neurochemistry of somatosensory pain processing. I hope you got something out of that, and hopefully I stuck to board relevant kind of questions or board relevant information for you, and it was a good review of the different receptors. These past few episodes kind of have been a little more technical, not as straightforward. So hopefully moving on forward, it's we're going to be actually talking about different drugs and how and which receptors they act upon. Because the main reason why I went through all of these with you is to show you that pain is a very complex system, that there's different methods in causing pain. So there's different components of it. So you have the inflammatory cascade, you have the different transduction of pain signaling. There's different receptors that are implicated in pain. And the important reason why you need to know this is they become different targets for different drugs. Hopefully you continue to hang on with me on the next few episodes as we kind of go through the different drugs that are commonly used in pain control. So we're going to talk about opioids systemically, then non-opioid analgesics, muscle relaxants, treatments for neuropathic pain, and so on. Okay, so yeah. So for today's fun fact I have for you is I'm getting a bunch of these from crack.com, but this one is the Ket people are one of the last true hunter and gatherer societies on Earth. They are an isolated population of about 1,200 people in Siberia, and their language is strikingly similar in structure to native North American languages. I mean, it kind of makes sense since if you believe in the land bridge theory, so you know how like humans like migrated from Africa and kind of just spread throughout, and Asia when the Bering Strait froze over, connecting Russia, now present day Russia to Alaska, and then the people kind of just migrated over. So it kind of makes sense, and I guess that's, if you call it, evidence of that kind of migration. So that's kind of interesting. All right, so that does it for this episode. I wrote down the credits this time, so hopefully it's a little more smooth. So the script and the show was produced by myself, intro music by Brian Teal. The source of information for this particular episode is from Benson Essentials of Pain Medicine 2017. This is the 4th edition, and this one was taken out of chapter 2. If you would be kind enough and you had time, please, give me a rating on Spotify or whatever you're listening to this podcast. I don't get paid for this. I kind of just do it for fun. And it's mainly just to give me feedback and give me motivation to keep going. So yeah, do it for me, basically. All right. But if you would like to contact me on any ideas or show notes or show ideas, episode ideas, or anything else, I have links to various social media accounts that I will try my best to monitor because I'm not too good at it in real life. So Facebook, Instagram, X, or formerly known as Twitter. Okay. That's pretty much it. Thank you so much for taking the time to listen. This is Scott, the anesthesia resident, and I look forward to seeing you in the next episode.